A patient presents with progressive weakness and back pain. Your MRI shows a spinal lesion, but is it inside the cord, outside it, or compressing it from the outside? This one decision completely changes management. Spinal lesions are classified into three main compartments. Intramedullary inside the spinal cord. Intradural extramedullary inside the dura, but outside the cord. Epidural outside the dura. MRI is the gold standard, while CT helps in bone involvement and calcifications. Intramedullary lesions. Gradual onset neurological deficit. Early motor weakness. Poorly localized pain. Late radicular pain. Symptoms start centrally and spread outward. Intradural extramedullary, subdural, lesions. Radicular pain is common and early. Sensory symptoms precede motor. Asymmetric deficits. Nerve root irritation comes early. Epidural lesions. Severe localized back pain. Rapid progression. Early nerve root compression. Possible spinal cord compression signs. Pain plus rapid deterioration is equal to red flag. MRI features the cord differentiation. Intramedullary lesions. Cord expansion. Lesion centered within cord. Ill-defined margins. T2 hyperintensity. Possible enhancement. Examples. Ependymoma. Astrocytoma. Demyelination. The cord is enlarged, that's your biggest clue. Intradural extramedullary lesions. CSF cleft sign. Displacement of cord, not expansion. Well-defined margins. Dural tail, meningioma. Examples. Meningioma. Schwannoma. The cord is pushed, not expanded. Epidural lesions. Located outside dura. Compressing the thecal sac. Often associated with bone destruction on CT. May extend through neural foramina. Examples. Metastasis. Epidural abscess. Disc herniation. Look for bone involvement and external compression. CT role, quick but important. CT is especially useful for detecting vertebral destruction, metastasis, calcifications, meningioma, fractures or bony canal compromise. MRI shows the lesion, CT explains the bone. Quick comparison, rapid revision. Cord expanded. Intramedullary. Cord displaced. Intradural extramedullary. Cord compressed from outside plus bone changes. Epidural. High-yield pitfalls. Large intradural lesions may mimic intramedullary. Severe epidural compression may obscure boundaries. Always check multiple planes, axial is key. Understanding the compartment is the first and most critical step in diagnosing spinal lesions. Master this, and spinal MRI becomes much easier. Thanks for watching, and don't forget, in radiology, location is diagnosis.
Differential diagnosis of spinal lesions. It can be classified into three groups: intramedullary lesions, or subdural extramedullary lesions, and epidural lesions. Normal anatomy of the spinal region from lateral to midline. It is formed from epidural fat, dural sac, subarachnoid space, which is cerebrospinal fluid space filling, in addition to the spinal cord. Any lesion arising from outside dural sac is epidural lesion, while any lesion arising from inside the dural sac and outside the cord is considered subdural extramedullary lesion. And if the lesion arises from the cord, it will be intramedullary lesions. Example of epidural lesions. We have on the right side an image of T1 plus contrast, while in the middle T2 image, sagittal image, On the left, we have two images, diffusion and ADC map axial images. Shows extensive peripheral enhancement of an epidural collection is noted posteriorly within the epidural space from L1 to S2 with diffusion restricted fluid. This results in compression of the cecal sac with severe compression of the coda equina and anterior dural displacement. Example of subdural extramedullary lesions. Here we have two images. On the right side, we have a T1 plus contrast sagittal image, while on the left side, we have also a sagittal image on T2 sequence. A homogeneously enhancing intradural extramedullary mass with a broad dural base, dural tail, and in the vertebral canal anteriorly at the level of T1 is demonstrated. It results in significant cord compression with flattening of the cord and obliteration of the cerebrospinal fluid space. The cord is displaced posterolaterally to the right. Mild associated cord signal hyperintensity is observed. The most important point here is the dura is in normal position. This is another example of intramedullary lesion. We have here sagittal image T1 plus contrast. Extending from C2, 3 to the midpoint of C4 is an intramedullary mass which is of high T2 signal, low T1 signal, and demonstrate prominent contrast enhancement seen on axial imaging, which are not present here. It has a prominent hemosiderin capping with some intrinsic high T1 signal consistent with hemorrhage. A moderate amount of vasogenic edema extends above and below the lesion from the crater cervical junctions to C7. The remainder of the cervical cord, the cervical vertebrae, and paraspinal soft tissues are unremarkable. The vertebral arteries are codominant to demonstrate normal flow voids. The most important point here also is the expanded cord. How to differentiate radiologically between these three types? Look to the condition of the cord. If expanded with or without cord edema, it will be intramedullary lesions. But if the cord is compressed plus widened cerebrospinal fluid space angle opposite lesion plus dural tail sign plus cerebrospinal fluid cleft sign, it will be subdural extramedullary. But if the cord is compressed plus bone destruction or scalloping of the neural foramen, it will be epidural lesions. In case of epidural lesions, the dura will be pushed from its normal site, while in case of subdural extramedullary, it shows normal position of the dura, and in case of intramedullary lesions, there is expanded cord. Key radiological tips. On axial image assessment, if the cerebrospinal fluid is visible completely around the lesion, it is intradural extramedullary. But if the cord is expanded, it is intramedullary. Intramedullary ependymoma often have a hemosiderin cap due to hemorrhage. Finally, if the dura is pushed inward, it is epidural plus bone destruction or scalloping. Regarding the most common intramedullary lesions, which are ependymoma, it is central imposition in the cord plus الهيموسيدرين cap, image 1. Or astrocytoma, it is eccentric imposition plus cerebrospinal fluid seeding, image 2. Or hemangioblastoma, it shows multiple cord, brainstem, and cerebellar lesions and could be a part of von Hippel-Lindau disease, image 3. Regarding the most common subdural extramedullary lesions, which are meningioma, it shows homogeneous enhancement plus dural tail and or dural base, image 1. Or neurofibroma or schwannoma, it shows heterogeneous enhancement with scalloping of the neural foramina, image 2. Or leptomeningeal metastasis, where it shows cerebrospinal fluid seeding, image 3. Regarding the most common epidural lesions, which could be meningioma, neurofibroma, schwannoma, extramedullary hematopoiesis, herniated nucleus pulposus, abscess, which shows ring enhancement and vertebral body destruction, or hematoma, which appears on T1 and T2 hyperintense with gradient blooming effect and no enhancement. Extramedullary hematopoiesis is due to failure of erythropoiesis in bone marrow. It affects visceral organs such as liver, spleen, lymph nodes, and thorax, and occurs in myeloproliferative disorders such as chronic myeloid leukemia, polycythemia vera, or Hodgkin lymphoma, or occurs in hemoglobinopathies such as sickle cell disease, thalassemia. Radiological signs includes diffuse visceromegaly such as liver and spleen. Lesions are typically hypermetabolic, hence FEG 18 PET avid. In addition to the posterior mediastinal mass, which is the most common sign, which could be unilateral or bilateral, with smooth, sharply delineated, often lobulated margin, and fat can be seen if chronic. Image A, transverse unenhanced CT scan of the upper abdomen, while image B and C, contrast enhanced CT scan of the upper abdomen. Images demonstrate hypoattenuating homogeneous soft tissue arrows in both renal pelvis with minimal enhancement. Notice the massive splenomegaly, S. A large cyst, arrowheads, is noted in the anterior cortex of the left kidney. L represent liver. Image A shows anterior whole body image obtained with technetium-99m sulfur colloid bone marrow imaging, while B is posterior whole body image. These images demonstrate no substantial peripheral marrow expansion. The hot spot in the left side was caused by contamination and is not pertinent. Massive splenomegaly is noted. Image C, anterior image obtained with technetium-99m sulfur colloid bone marrow imaging with a wide window setting, while D, posterior image. These images demonstrate radiotracer uptake in only the liver and the spleen. Note that the region of the kidneys shows no appreciable radiotracer uptake. Regarding الكودا equina lesions, it could be ependymoma, which is the most common, neurofibroma or schwannoma, or leptomeningeal metastasis.